I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series, and I'm also a patient living with MPA vasculitis. Today, we'll be following up on some questions about the skin and vasculitis that were not answered in a previously recorded webinar. And these webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. We're super grateful today to have Dr. Galen Folk back with us to answer questions about our skin and vasculitis. And so I'd like to begin by introducing Dr. Folk. He is an associate professor of dermatology and public health sciences at Penn State University. He's the co-director of the Rheumatology Dermatology Clinic at Penn State and has a special interest in vasculitis and related autoimmune diseases. I hope I did the correct introduction there, Dr. Folk, and we're so happy to have you with us today.
Oh, it's so great to be here. It's a very kind introduction, Kathy. Thank you so much, and so grateful to have the opportunity to talk more with patients and answer their questions.
Okay, great. Before we get started, I'd like to ask if you have any disclosures today.
None that are relevant to our talk today. I have served as a consultant for AstraZeneca, and I have received a Career Development Award from the Dermatology Foundation, but none of that was related to the study or treatment of vasculitis.
Okay, well, thank you for giving us that information. And we got some questions. We got many questions after the last webinar, and quite a few went unanswered because we ran out of time, as we often do. So thank you so much for coming back. And if it's all right, I'll just get started with some of the questions that we'd like you to answer today.
That'd be great.
All right, so the first one is from a patient. Can a bite or rash trigger a flare, as in skin trauma?
Sure. So the best answer is there is a chance that that could happen. Anything that is an insult to our immune system can raise its activity and raise the activity of our immune system, all the good things that it does and the bad things that it does. So while I don't think we need to be hyper cautious and mosquito bites and bee stings happen, is there a chance? Sure. That chance is small, but it's possible, especially, let's say, we were talking more about bites and trauma. If you were to get a serious infection from that, that would be much more likely to stimulate it than the bite or the sting itself. A fall, a scrape, those will heal just fine. But even patients without vasculitis can get an infection from time to time. But a bad infection can certainly stimulate the immune system, could potentially cause a flare. But again, those chances are small, and I would not be overly stressed about it.
Okay, I actually think that answers the second question, was about somebody who is highly allergic to bee stings. They've been in remission 1.5 years and just wondered if they got stung, could it trigger a relapse? But it sounds like you're saying it could, not likely.
Yeah, the answer is about the same. I would say if you're highly allergic to bee stings, you're already going to be avoiding those nasty little bugs to begin with. So just keep doing what you're doing to protect yourself from the allergy of the bee sting. Possible, but again, I wouldn't be overly stressed about it.
Okay, and this next patient says, I'm a patient living with vasculitis and I love to bike. I had a small accident and scraped up my knee, some minor bleeding, not too serious, cleaned the wound and bandaged it, but that area still hasn't healed and it's been over a week. It's very red and inflamed. As a patient with GPA, am I more vulnerable to infections from an accident like this one? And am I susceptible if I have a wound?
That's a great question. There's several ways to answer this. If this patient, many GPA patients are on treatment with a medication that modulates the immune system. Many, but not all of those medicines make it slightly easier to get an infection. So getting that infection appropriately washed, cleaned, and evaluated by a doctor is super important for that reason. When we have an autoimmune disease, a way to simply state it is that our immune system is wasting some of its energy and focus on attacking parts of us instead of germs when they come in. So patients with autoimmune disease, that when that disease is active, probably again have a slightly increased risk of infection compared to some of their peers. I don't know that that's been studied specifically in vasculitis, but because it's this particular case is still red and angry, that they should have that evaluated by their doctor. And we have to remember, maybe the most important takeaway from this question is that patients with vasculitis get all the same stuff and problems that people without vasculitis have. I think sometimes, especially as doctors, we can be a little bit quick to blame the vasculitis for any little thing that pops up. And so if you scraped your leg on the road, you could have a little piece of rock stuck in there that's causing some persistent inflammation. It's important just to have that. I don't want anybody to be too quick to go to vasculitis and forget to think about the things that anybody who's a human being can get.
Sounds like a great answer. I was just thinking while you were talking that my doctor, who we both know, told me when I was in very active treatment in the early years that if I had an open wound, I'd cut myself with a knife or anything like that, make sure I just kept it covered. Is that good advice, just to not introduce any germs into it if I possibly could?
It's a great idea. I mean, any wound should be washed thoroughly with soap and water, let it dry. And if it's open, a good layer of Vaseline jelly and a nice Band-Aid over top is going to help keep the bad stuff out and promote an environment that optimizes healing. We don't necessarily recommend you go right to topical antibiotics or anything like that. But yeah, covered with some Vaseline jelly, change that bandage at least daily. That's important too, especially when you're on those important medications. Change the bandage daily, fresh layer of Vaseline jelly, and you're doing all the right things.
What great advice. I'm not sure all of us would have known that or thought of that. So thank you. I have someone else that says, can small vessel vasculitis evolve into medium or large vasculitis?
That's pretty unusual. Usually the type of vasculitis that you have is the type of vasculitis that you have. So if you have IgA small vessel vasculitis, that's what you have, and that's what you're going to treat. The Ankylosing family is a little bit unique because they straddle the line between small and medium from a dermatology standpoint. They are firmly classified as small vessel disease, but they can start to show some of the features of medium vessel stuff in the skin. There are a small number of vasculitides that can affect any vessel type, and they can move between categories. This would be entities like cryoglobulonemic vasculitis. Cryoglobulonemic vasculitis can present as small or medium, move back and forth, sometimes maybe even have some large vessel findings. But that's a discrete diagnosis. So if you have rheumatoid type small vessel vasculitis, that's what you have. So for the most part, no, there are a small number of vasculitides that can move across the categorizations. Cryoglobulonemic, Behçet syndrome, Kogan syndrome, and a small number of those.
Gosh, thank you. I didn't even know that. So this next patient says, with EGPA, will Nucala or other biologics help with skin lesions?
Sure. I work at a university, so I have to use the generic names. Mepolizumab. Yeah, there's a publication. There's a couple publications of mepolizumab for EGPA. I have not had the experience using that medication specifically, but there are at least some articles that discuss its potential. It'd probably be a little further down the line. There's some articles too as well describing the biologic dupilumab, which is an atopic dermatitis medication. Maybe some of you have heard of. There's been some publications of that being used for EGPA. However, there are also a small number of publications where patients developed EGPA after being on dupilumab. So the jury's still out on that. But I think the question asker also asked about other biologics. We have to remember rituximab is a biologic, and rituximab is an important part of many patients' vasculitis treatment algorithm.
Okay, very interesting. The next patient asks, has IVIG ever been used to treat skin vasculitis symptoms?
Definitely, absolutely. And in select cases where patients are struggling to respond to more typical agents, it's something that we consider. I generally would use rituximab first, so we would go through our typical stuff. If we're talking skin vasculitis, we like to use some prednisone to see if we can just push it into remission with a short dose. If that doesn't work, we'll use what we call the DMARDs, disease-modifying anti-rheumatic drugs, so methotrexate, mycophenolate, azathioprine. If we're not getting that where we need to with that, or if the patient has particularly severe disease, rituximab usually solves that problem for us. But IVIG is a little further down that algorithm if we're needing additional help.
Okay, I had heard of some friends that had rituximab and then IVIG, so I wasn't sure. Interesting. Okay, and what types of vasculitis should not be tested with TNF inhibitors?
Oh, okay. Yeah, so actually I did think in my talk, I mentioned quickly that there were, I think one of the patients I presented had vasculitis develop around a time where they were on a TNF inhibitors. So there are some vasculitides that respond well to TNF inhibitors. Members of the polyarteritis nodosa family can be treated with that. But there are some vasculitides where we would hesitate to use a TNF inhibitor. These are especially the vasculitides that are associated with lupus or Sjogren's syndrome or related systemic autoimmune diseases. It can make those worse. And certain small vessel vasculitides, like cancer-associated vasculitis, we would not be eager to use a TNF inhibitor for either. There's other more niche cases, but those are the ones that would be the most instructive.
Okay, and since I am the lay person here and I don't know what a TNF inhibitor is, or I
Oh
don't
my
remember
gosh.
what a TNF
Yeah,
inhibitor is, can you elaborate a little bit?
sure. Oh my gosh, my glasses are very thick. I get very nerdy, and we get ahead of ourselves. Yeah, so that's called a tumor necrosis factor inhibitor. A tumor necrosis factor inhibitor is a type of biologic medicine, meaning that it is manufactured using biologic means to make what are functionally particles that can interfere. Oftentimes they're antibodies. We make antibodies. A lot of these are really interesting. They have like this big vat of bacteria that they've trained to make these proteins and these antibodies, and they harvest it, and then we use it for a specific target. The TNF inhibitors were originally used to treat things like rheumatoid arthritis and psoriasis, and we still use those to this day. In fact, I should then take a step back and readdress our mepolizumab and dupilumab question, shouldn't I? Mepolizumab and dupilumab are biologics that work in an axis of the immune system that includes eosinophils, which are a type of white blood cell that have a lot to do with EGPA. The E in that name is eosinophilic, and that refers to an abundance of this white blood cell, the eosinophil. They're very beautiful under the microscope. They have this very pretty magenta color. It'd be worth looking up if you're really into the science of it. They're a strikingly beautiful cell. But mepolizumab and dupilumab kind of work to repress the axis of the immune system that they're working in. So that's probably why that patient was asking about it. And I'm sorry that I didn't clarify that earlier.
Oh, no, that's okay. I just, I never know if it's something that everybody knows and I don't know, but I figure if there are people new to vasculitis that they might share in the explanation. So I appreciate that. And another one is coming up now.
Great.
So this next patient asks, with EGPA, is the Koebner, I hope I said that right, Koebner phenomenon something that is recognized? I knew it is more specific to other issues unrelated to vasculitis, but is it possible?
Yeah, yeah, this is an educated group, Kathy. And that's probably why I just, oh yeah, TNF inhibitors, and I started talking about them. These questions are so well structured. So the Koebner phenomenon, you nailed the pronunciation, great job, is a phenomenon where when the skin is injured or traumatized, the disease shows up in that area. Probably the most well-known Koebner phenomenon is psoriasis. Patients with psoriasis, if a lot of them, if they were scratched or burned, the psoriasis will appear in that area. And psoriasis tends to appear on areas that the patient is frequently rubbing, bumping, or touching, such as the elbows, knees, etc. Koebner phenomenon is described across a lot of diseases, and I have seen an awful lot of patients with diseases that are not classically associated with the Koebner phenomenon who Koebnerize. So there are absolutely reports of patients with EGPA Koebnerizing. I would never doubt a patient who experienced that. It's not typical for vasculitis. What we tend to see, we see a lot of linear things with small vessel vasculitis or vasculitis that's set up in a line. A lot of times it's at pressure points like sock bands, waistbands, belt lines, bra strap areas. And something about the pressure on that area can accentuate vasculitis under it. That's maybe not the same thing as what Koebner was talking about originally when he described this process, but it's so close that we'd be splitting hairs. So I wonder if maybe that's what the patient may be experiencing. But if the patient scratches themselves and they get an eruption in that area, that's totally possible. Being an eosinophilic disorder, there's a lot of overlap with other allergy type processes. And so maybe a lot of people here have heard of hives, or what doctors call urticaria. There's lots of different types of urticaria that show up on the skin after you scratch it. There's a type of hives called dermatographism, which in Greek means like to write on the skin, where if you like take a sharp point like a stylus and write a letter on a person's skin, within a minute or two, there'll be a raised welt in the perfect areas where you wrote. So I have seen patients with EGPA that have had that dermatographism. Is it the same thing? Is it part of the disease? Is it just part of this broader eosinophilic relationship with allergy? I'm not sure, but all of that fits pretty closely with what can be defined as a Koebner's reaction.
Very interesting, and a couple of new words for me to understand now. Thank you so much.
Yeah.
So the next one is I have small vessel vasculitis associated with PR3. Is the tingling in my lower legs and feet a symptom of it?
That's a great question. And obviously, we can't speak to an individual experience, but we know that GPA and ANCA-associated vasculitis in general associates with neuropathy. So the nerves need a blood supply just like every other part of the body, and vasculitis can injure that blood supply. And that can cause changes related to what any nerve does. So nerves do things like make us move. So some patients will have difficulty moving a part of their body if that nerve is involved. So wrist drop is a common thing where the radial nerve is injured and the patient's unable to lift up the hand on their own. But that could be in sensory nerves where you could experience numbness, tingling, or weakness. It maybe is a little bit more characteristic if it's asymmetrical, but certainly possible to have both at the same time. But again, I think we always need to remember that we can't be in a rush to chalk everything up to vasculitis. We have to explore the typical stuff. So we would want to make sure that other things like diabetes aren't the case. Some vasculitides are treated with the medication dapsone. Dapsone is quite good at causing neuropathy. That would be something to consider as well. And other things like sciatic injury, arthritis in the back. So that should be discussed with a physician for sure. We want to get to the bottom of that. But vasculitis can impact nerves. So can other things, including medicines used to treat vasculitis.
Okay, and one last question today, maybe two, we'll see. This one says it's a question that's slightly off topic from vasculitis, but somewhat related. Does a skin reaction from taking antibiotics look different or have characteristics that you recognize? Do you get welts as a side effect or just an itchy rash?
That's a great question. Medication reactions have a really broad and diverse spectrum of skin involvement. So there are a lot of different rashes that a reaction to a medication can cause. However, the majority of reactions to antibiotics belong to classification we call the morbilliform eruption. So most antibiotic allergies show up as these really fine, we use the medical term papule, but papule just means a bump, a very small bump, less than a centimeter or a half centimeter. These are like a couple millimeters in size. They're these tiny little bumps, and we call it monomorphous, meaning that the bumps, it looks like if the bumps were on a computer and you could click copy and then hit paste 1,000,000 times and just reproduce the same bump over and over again, put it on the center of a patient's body. That's what it looks like, this copy of these tiny, tiny little pale pink bumps, all clustered really close to each other, erupting on the center part of the body, and then kind of over time working their way out the limbs. That's called a morbilliform drug eruption, and that is far and away the most common eruption that patients have. So for the most part, if we see a morbilliform eruption, that is either caused by a medication or caused by an infection. They can do that too. But let's say you started the antibiotic sulfamethoxazole trimethoprim. That's one of the most common causes of the morbilliform eruption. And then, 5 to 7 days later, boom, you erupt in this very, very itchy rash. Sometimes it's less than that, sometimes it's more than that. We would know pretty confidently that that's a reaction to that medicine. I want to make sure that I'm not misrepresenting the question. Some patients will ask us, does each drug have its own characteristic skin eruption? No. We can't tell whether your morbilliform eruption is from antibiotic, blood pressure medicine, seizure medicine, you name it. They can all appear, they can all cause very, very similar stuff. There are drugs that can, as a reaction, can cause vasculitis. The antibiotic minocycline is well known to have vasculitis as a rare side effect, for example. And the blood pressure medicine lisinopril can cause an autoimmune skin eruption called bullous pemphigoid that looks like big, huge blisters on the skin. I mean, like centimeters across. But you take the medicine away, and in general, they get better. So the short answer is dermatologists usually have a pretty good idea when your rash is from a medication. But there's also no definitive test. We can't biopsy your skin. We can't draw a blood test. There's no way to prove through a skin test that you're allergic to that medicine. It's all based on timing. It's a little bit like a jury trial for a crime. We can never, the jury wasn't there. They can never be 100% sure, but they can be pretty sure based on the evidence.
Very, very interesting. And that made me think about something else with some very characteristic rashes that we are getting ready to do a webinar about, shingles. I happen to be somebody who has had shingles twice, so I know about the rashes, but could you talk a little bit about skin involvement with shingles?
Yeah, actually, I have a couple research papers published on shingles, a couple of them in the last year. So yeah, this is a fated coincidence. Shingles is a reactivation of a virus, the chickenpox virus, also called varicella zoster. In fact, we tend to call shingles with the medical term zoster. The virus, after we've had it, lives in our central nervous system for the rest of our lives. And every once in a while, the virus will wake up, begin replicating, and travel down the nerves from the spinal cord. And wherever those nerves go, and most of them go to the skin, they get to the skin, and in the area that nerve controls, you'll get an eruption that usually starts with burning and tingling because the virus itself is injuring the nerve. And when you injure a nerve, any point on its pathway back to the brain, if you injure that nerve up in the neck, for example, your brain will perceive it as a problem down here rather than where you're poking it. So you get this burning and tingling, and then often you get this eruption of little bumps that turn into tiny blisters. We call them vesicles. You heard me say the word bulla earlier. That's the medical name for a very large blister. A small blister is called a vesicle. So you get these vesicles that are clustered up. Again, copy, paste, 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 paste. They all look very similar to each other. They're tightly clustered. They're in kind of a straight line, and they stop at the midline of your body, and they're only on one side. But they can be on the face, the neck, the ear, the arms, the chest, the legs, anywhere that you have nerves, which is pretty much everywhere. Shingles could pop up. But one of its key features is that it's just one side. Burns and stings, and as that heals, those blisters eventually will break. You'll get scabbing and crusting. And then a lot of times, once that heals up, you'll have some skin color loss in the areas where you had the blisters, and that can last for many, many months. But the skin usually heals beautifully. Patients can also have long-lasting burning, tingling, itching, numbness in the area that they had the shingles. But the skin itself is totally fine. That skin is healed. It's the nerve that innervates that area that's damaged from the infection. So the patients often feel a lot of burning and tingling on their skin. Sometimes they come to dermatology. How do we fix my skin? And we have to explain your skin has healed perfectly. unfortunately, that nerve is persistently injured, leading to ongoing symptoms. And so our treatments are to help the nerve rather than the skin. Does that make sense?
It does, and it's so interesting to hear you talk about it. This last episode I had, it's a long story. I'm getting the vaccines now, but they were waiting because of other medications. I was in between. Anyway, my last episode started back here and went like this.
Yeah. Oh no.
But
Yeah.
it was so interesting to me about the midline thing because it only stayed on this
Yep.
side. And they said that's how they definitively knew that was a
Mhm.
part of it.
Yeah.
So
Nerves.
interesting.
Yeah, nerves from our brain. We have two halves of our brain, and it's very interesting. The nerves only go to one half of the body related to that. It's very interesting because actually they cross. And so in a lot of places, the right side of the brain is dealing with the left side of your body. So it can be a little counterintuitive, but those nerves cross. But those nerves, when they come out, they stop right at the midline because the nerves from the other side also do. It's probably important to note, Kathy, that involvement that comes close to the eye or close to the nose is considered an emergency, and those patients should see ophthalmology right away because involvement of the outer layers of the eye is possible, and that can lead to scarring and vision loss. So
Yep,
very, very important.
I was sent to an ophthalmologist right away. It just started here, but I didn't know what it was until blisters appeared here.
Oh, poor.
And
I'm
then
so
they
sorry.
went down. But my skin's clear.
That's great.
No vision loss, nothing, worked out fine. It was just very interesting. Another fun fact of life.
Yeah.
So that was it for our questions, and I so much appreciate the time that you spent with us today. We did want to do, oh, I cannot share the thank you screen, Ed, because I'm not a host. So I will just say, we did want to thank the Vasculitis Foundation for providing these educational webinars for us. And we want to also thank our sponsors, AstraZeneca and Amgen and Novartis. And of course, Dr. Folk, for spending all your time with us today, answering these questions. Great job answering the skin questions. There's so many of them today. Thank you so much.
It's so fun to do it. I'm so grateful for the opportunity to work with you again. And it's always fantastic to have an opportunity to help patients understand what's going on. And I learn so much from our patients, and they answer all my questions. So I have to be fair and try to answer theirs, right?